Okay, so I'm going to be going over now the cardiovascular and peripheral vascular system assessments. And again, like the other ones, we're sort of doing a snapshot of that system, but they kind of all fit in well together. But we'll just kind of break it down individually. So always you want to do a quick general inspection when you walk in and see your patient. Talk to them, introduce yourself, explain what you're going to be doing. Doing a set of vital signs is a good idea. And we're going to, again, sort of narrow down the questions that we ask. All those sort of larger historical questions would likely have been asked on admission or in the chart. So we can just ask some basic questions that we ask on a daily basis or in every shift or as needed. But if they're having any chest pain or chest tightness, are they having any sort of peripheral swelling or pain in their calves especially? Are they having any shortness of breath or activity intolerance? That's different when they get up to do something that they're finding it a lot more difficult to stay oxygenated, that kind of thing. So we would ask those questions. So we're going to kind of start, kind of do it in a head to toe fashion. And we're going to start by just looking at his carotids. Some people you can actually see a bit of a pulsation, and we're going to go ahead and palpate them and explain that to the patient. We're going to find it just medial of the sternomastoid muscle, and you actually can see a bit of a pulse there. And you want to be careful, so you just can use about 2 fingers. And yeah, I can feel it, it's about a +2. You want to be careful not to go in the carotid sinus and massage there in any way. That can cause vagal stimulation and actually decrease their heart rate. And you also want to note, it's tempting maybe, but you don't want to palpate the carotid simultaneously because you can actually cut off blood flow to their brain, and that would not be good. At this point, too, we can also auscultate the carotids. So we would be listening. And you can listen with the bell and with the diaphragm of your stethoscope. And we're listening for any sort of bruits there, so giving us a signal that there's turbulent blood flow happening there. Typically, you actually don't hear anything. You don't really want to hear anything. On some people, though, you can hear a referred pulse. So you want to kind of suss out that, is it a bruit, is it turbulent blood flow, or is it just a referred pulse from the heart? So that's starting from the top, going down. We'll look at maybe his arms next, kind of seeing that the hair distribution, the color, the warmth, the circulation. And to check circulation, we can do some cap refill checking. So you want it to be less than 2 seconds normally. We can check pulses here. So check his brachial pulse right in that antecubital fossa there. And we can check his radial pulses. And you'd want to do this bilaterally and compare. Good. Good. So again, looking, just kind of doing inspection and sort of light pulse palpation as well. We're going to move on to the precordium. So I'm going to ask our patient to take down his gown. And again, we're going to start with inspection. So just looking at the chest, looking for any lifts or heaves or abnormalities. And this Precordium assessment, we're actually going to listen to heart sounds and at the different valve areas. It's not always done in every nursing assessment or nursing area, I should say, but it is good to understand where you would auscultate those different heart sounds, where you would auscultate those different valves, and heart sounds. And so if your patient did have a murmur or suspected murmur, you could listen to where it's happening and sort of characterize it. So we usually start at the base of the heart, which actually is sort of what we think of anatomically as the top. The base of the heart is sort of that, the heart is shaped like a triangle a little bit. So we're going to start at the base. We're going to listen to the aortic valve, the pulmonic valve, the tricuspid, and then the mitral. And we'll sort of explain the rough landmarking using intercostal spaces of how to find those, and then what you'd be listening for at each one. So the normal sounds of the heart we refer to as S1 and S2. Those are the valve closure sounds that you'll be hearing, or the lub-dub. S2 is louder at the base, S1 is louder at the apex. And so just noting that throughout, you shouldn't really hear any additional sounds. So we'll want to be, while we're listening to those S1 and S2 sounds, want to be listening for any additional sounds like murmurs. If we notice them, we want to note the pitch, the amplitude of it, where it's happening. Is it happening in systole or diastole, that kind of thing. As best you can, sort of try to name the characteristics of it. But that's sort of, again, an advanced skill. So we'll just start with listening to those S1 and S2 sounds and finding them. So you want to do this both with the bell and the diaphragm of your stethoscope, so you can kind of follow that Z pattern twice. And how you actually start is where the manubrium meets the body of the sternum, there's a little notch on most people. I'm probably a little low on you, sorry. So it's below the suprasternal notch, and then just left and right of there is actually the second intercostal space. So you can go ahead and try to feel that on yourself even, but that little notch there, it's called the angle of Louis. So the angle of Louis is our helpful starting point, landmarking point, because just left and just right of the angle of Louis, you'll actually find that you're in the second intercostal space. So that's actually a really helpful landmarker on most people. It's findable, and you could even have them lay flat if they had more tissue there. So on most people it's findable, and we just want to go left and right of the angle of Louis. So we're in the second intercostal space on the right side, and you might be thinking, but your heart is on the left side. That's correct for the most part, but it is, you can hear your aortic valve in that right second intercostal space along the sternal border. So you kind of want to envision along the sternal border, this is where we're going to hear our first aortic sound. So you can hear that obvious S1 and S2, S2 being a little bit louder. And then we're going to move over to the second intercostal space on the left side. And that's where we're going to hear the pulmonic valve. The pulmonic valve is kind of interesting because typically the S1s happen simultaneously and the S2s happen simultaneously. But with the pulmonic valve, if you listen here and ask your patient to take a big, deep breath in and out, you can sometimes catch a splitting of the S2 so that they're not quite as synchronous, and you hear that split S2 there. So it's sort of like lub-dub, very quick, but you can hear that split sometimes. And now now we know we're in our second intercostal space along the sternal border, and you can now kind of count down the ribs. So third, fourth. So at the fourth intercostal space along the sternal border, you can actually hear Erb's point, and that's where S1 and S2 are more or less equal. And if we move down to the fifth intercostal space, this is where we'll hear our tricuspid valve. So again, S1 is a little bit louder than S2 here, or should be. And it's again along the sternal border. And now if we move out, so if we want to go to the fifth intercostal space, which we are at, and we're actually going to want to go now mid-clavicular line. So we can see our patient's clavicle and just eyeball the middle mid-clavicular line and follow that rib out. That's where we're going to have, that's where the apex of the heart is. That's where we're going to hear our mitral valve. You'll also hear this called the PMI, or point of maximal impulse, or apical pulse. It has a lot of different sort of names, but they all mean roughly the same thing, that this is the apex of the heart. So this is where you should always, if you're taking an apical pulse because the person has an arrhythmia or is on digoxin, this is where you would be finding that pulse. So fifth intercostal space, midclavicular line. And you can actually see it is in line with a lot of patients' nipples, but you don't want to use the nipple as a landmark because it can move. It's a little bit different on everybody. It's a little bit more accurate if you use those bony landmarks that we just went over. So you'll want to listen there. Same thing with the bell and diaphragm when you go through the Z method landmarking. And you should hear the pulse there. If you're taking an apical heart rate, you'd want to listen for a full minute and note any irregularities. You could also be auscultating here and palpating the carotid at the same time to note any sort of a pulse deficit if they have. And on some people, you can actually palpate that apical heart rate or that PMI. Sort of on thinner people, it's not on everybody that you can palpate it, so don't worry if you can't, but you should be able to auscultate it, hear it on everybody. And as you probably have guessed, for women, it's a little bit more difficult because of breast tissue, so you can still palpate out the different intercostal spaces. You can have them help you by displacing their breast tissue, and it may help when listening to the precordium to have somebody laying down too. Another good idea or something you can try is if you're having a hard time palpating it, and it seems like you should be able to palpate it on that person's body type, or even auscultating it, it can help to actually tip the person. So if we asked, you don't have to do it now, but if the patient lays on their left side, it actually brings the apex a little bit forward, and you can sometimes hear it a little bit better that way. So you could have them lay on the left side, sort of tipped forward a little bit. So those are the general that's the general rules of listening to the precordium. So you want to follow that aortic, pulmonic. You can listen at herbs, tricuspid, and mitral. And you want to listen with your bell and your diaphragm, noting any extra heart sounds or murmurs. And then taking that apical pulse there is how you would find that too. Just kind of a quick summary. So we'll cover up our patient for now, and we'll get you to lay down if that's okay. This out for you. So carrying on with our now sort of peripheral vascular combined, we could ask our patient, we could look at their abdomen again. I'm just going to pull this up. And again, we would cover the patient as best we could with, if we had a blanket, in this case, he's comfortable wearing shorts. So looking at that aortic pulsation on people, sometimes who are thinner, we can see that actual pulsation. You can palpate it in a lot of cases, and then you can imagine that splitting off into its iliac and then femoral arteries. So you can palpate, and you would want to know how to landmark and palpate the femoral pulses. You don't have to do that, of course, in lab on your partners. It's kind of intimate, but you can try it on yourself. It's just between the pubic bone and the iliac spine, and so you just want to feel for that femoral pulse. And then again, moving down, we want to feel those peripheral pulses. And while we're palpating or going to palpate and landmark, we're also noting the hair distribution, the color, the warmth, those signs of circulation. We can check again cap refill on the toes. Seeing hair on the toes is a good sign that he is perfusing his feet well, and his legs feel warm, good color, and again, good hair distribution. So we'll start with the popliteal pulse, and you can just bend your knee a little bit. Thank you. So this is a notoriously difficult to feel pulse, but if you start sort of right in the popliteal fossa and then move your fingers out progressively, you can usually capture it there. So I usually like to start like this and then ask the patient to straighten their leg out now. Just let it lay flat. And we can sort of lightly palpate it there. So you want to compare, of course, on either leg. We're also looking at this point for any sort of swelling or edema. If he did have swelling or edema, we would want to check if it was pitting, and then sort of rate the level of the pitting. And again, you want to, it's a little bit of a subjective scale, but you want to try to be as objective as you can, noting the pitting, and you want to note, say, or the edema, where that stops and starts. Maybe it's just below his knee, and maybe it's unilateral, or is it on both legs? If it's unilateral, especially in the calves, that can be an ominous sign of a blood clot, so we wouldn't want to agitate that much. You want to feel if it's warm. You could even measure the calves, so on. So those are things sort of we're thinking about while we're in this this area. So we would do the same, feel the popliteal fossa, the popliteal pulse on the left leg, and now we're going to follow that pulse down, and we're going to feel for the dorsalis pedis. So we're going to find the dorsalis pedis pulse just parallel to the great toe tendon, and a little bit lateral there. Good. And you want to do the same on both sides. And then we're also going to feel for the posterior tibial pulse. So between the medial malleolus and the Achilles tendon is typically where that is found. And same idea, you want to palpate that bilaterally and compare. So a Doppler is an ultrasound machine that will pick up that pulse. It's a little bit more sensitive sometimes than your fingers when it's difficult to palpate. So it uses that conduction gel. You can either put it on the patient or on the device itself. Maybe we'll put it on you. And turn it on. Just going to apply gentle pressure. So you can hear that pulse. He's at about 60 for the resting heart rate. So we'll just clean off our machine after and wipe off our patient. But that's sort of the general CVS and PVS assessment.